Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the Quorum Podcast. Today, Dr. Winston de Mello will be discussing the first responders management of severe burns. Dr. de Mello is one of the founders of the college. He's a burn consultant, pain consultant. He sits on the British Burns Association as chairman, I believe. Is that right, Winston?
Yes, it is.
And you have extensive experience with burns in the operational setting as well as in the civilian setting. So, Winston, how did you get your interest in burns?
It just coincided with the Falklands War, as many people will realize. It's 40 years ago. I was just a very junior hospital doctor in the military hospital in Aldershot. And since 1982, there were several occasions when myself and other doctors like Phil Ward, who you know, were anesthetizing these burn victims several months, years after their original burn injury in the Falklands. So that's how it all started. And then just fortuitously, when I left the military, I managed to get into Manchester and work on the burn centre at Wythenshawe Hospital, both as a consultant anaesthetist on a Monday afternoon list and for a multidisciplinary team meeting every Wednesday morning as the pain consultant. So I've had quite an extensive experience in major burns.
And you've presented quite a bit on burns. You've presented in seminars and in conferences with the Special Operations Medical Association. Just recently, you presented at the Combat Medical Conference in Paris. So you've done a lot of presentations on burns and pain as well.
It's just a part of the development that we've had at Quorum. If it wasn't for Quorum, these opportunities wouldn't have arisen. So I think it's a symbiosis of my involvement with Quorum and passing on the baton to the next generation of specialists or first responders who will be facing a patient with a major burn.
But so major burns cause so much stress for first responders, for healthcare providers. What is the etiology of the stress? Why is burns such a big topic?
Well, as you know, burns and severe head injuries are what we call distracting injuries. First of all, a major burn is rare. There are about 13,000 cases of burns in England and Wales annually. But the median size of the burn is just 1 to 2%. So the chances of you dealing with a major burn on a regular basis is fortunately rare. And what makes it even more difficult is that of all the major burns, just 5 to 7% will have other injuries. So this we'll discuss later. And of all trauma, just 1% is by major burns. So even in the trauma world, it's very rare. Therefore, I think when you're confronting a major burn, especially if they're still alive, the pain, the smell of burnt flesh, is quite overpowering. And until you engage your CABC, you'll make a mistake. And I guess that's the reason why when we teach in Quorum things about burns, we make sure that they understand that they have to have scene safety and then go through the logical CABC process.
You never forget the smell of burns or the burn casualty. My first burns experience was 1993 with the Green Ramp accident at Fort Bragg, where 2 airplanes crashed and one of them was full of 160 paratroopers. And so by the time they were coming into the Fort Bragg hospital there profound amount of major burns. And as you walked along the corridor, you could just smell the burns. And it's a very difficult thing to address because the pain, the screaming, the vast damage that the burns have. It was traumatic for me. So as a paramedic, we come across the burn casualties very often after the fact, and it's the first responders' actions that are so important. Why is that?
As you know, during our courses in Quorum, when we teach paramedics, especially when they're working in an isolated environment, good management of a major burn in the pre-hospital environment reduces the total body surface area burnt and also reduces the depth of the burn. So in just doing basic interventions, but doing it well, you will reduce the morbidity and obviously mortality. The second is that it will reduce health costs, because if your burn is smaller, your depth of burn is less, then it's going to be less expensive during their stay through the journey from intensive care right through to rehabilitation. And probably something that is not picked up, but certainly my experience in dealing with pain in burn patients, a good analgesia given early on and as soon as possible, but still following the CABC, means that the outcome for the patient is going to be better than if the basics weren't done well.
Mm. And heat is an obvious cause. There's quite a few different etiologies. What else besides heat would cause these burns?
Heat is the one that we traditionally sort of can understand, but you know my feelings about ice packs. You know, I worry about, for example, causing injury by ice packs. So cold is another one. Friction burns, like if somebody's dragged across the street or whatever. That can be. It's almost like a degloving injury. Chemical acid alkali, of which cement is a common work and industry issue. And sadly, due to the current military situation in Eastern Europe, the use of phosphorus in missiles. And then there is the electrical ones, which are usually industry, and also the high voltage, which can be devastating injuries because that can result in a whole lot of tissue loss right to the bone, and obviously electrical storms. And finally, the most common one is radiation. You know, some of us like to have a nice tan skin, so sun exposure, but it can be nasty, and also radiation from industry and from military sources. So there's a wide spectrum of sources of burns. And I think it's important that as a pre-hospital responder, the first responder, is to try and work out the etiology of the burn, as sometimes it may not be so obvious. And the second thing is, if you are forensic about your history taking, you will cut the need for the hospital then to go back to the scene where it may not be possible to do so, and try and get information of what the chemical was, or what the source of radiation was, or what the mechanism of injury was. So I think in terms of etiology, keep an open mind, try and get as much information if they're bystanders, or if it's an industrial site of a burn, then get the necessary details from the foreman, and give as much information to the receiving hospital.
Your point on history taking is often looked over. Like Oliver Wendell Holmes said, what 95% of diagnosis comes from history, and that works in trauma as well, doesn't it? For burns, we need to know precisely what happened.
Yes, you're right. And I think, I always say to people, history should give you a framework. In the case of burns, the etiology. And once you know the etiology, you can then individualize your treatment. For example, if it's a chemical and it can be washed off, then you go ahead and do it, because as soon as you decontaminate the wound, the better. Secondly, if you know that it's a powder, and the powder is caustic, say, when it gets in contact with water, then you could brush it off carefully whilst making sure that you've got full PPE on.
Speaking of that approach, so how do you clinically manage this? So you have someone with a burn. How do you approach this, and how do you assess this, and how do you manage this?
Well, like I said, burn is a distracting injury, and occasionally, rarely, trauma and burn may coexist. I think it's important to try and get the history and the mechanism of injury. We talked about scene safety, and then I like the SAFE approach, which we used in the battles course in the military, where S is for shout for help, A, assess the scene, F, free from danger, and then evaluate. in either CABC or March, depending whether you're in the UK or in the United States. The most important thing is to stop the burning process, cool the burn wound, but not the patient. 3, cover the burn. And 4, elevate if possible. And if the patient has a head and neck burn, sit them up unless there is a contraindication, because it is going to reduce the chances of having to intubate these patients.
So intubation is definitely the last ditch effort for your airway ladder. Why are inhalation burns so dangerous for the airway?
Inhalational burns are dangerous because if the thermal energy that's been transferred from the source of burn will overwhelm the cooling processes of your nose and upper airway, then it will destroy and inflame the mucosa. So you're going to get swelling. And when you get swelling, you will eventually develop stridor. So that's one issue. The second issue, which is probably most sinister, is that if it's a burn in a confined room, the chances of carboxyhemoglobin or cyanhemoglobin, any one of the dyshemoglobins, becomes a problem, and the patient will die from systemic toxicity if you're not careful. Furthermore, when you inhale micro sizes of soot, this causes a chemical reaction within the lower airway, and then leads on to the eventual acute lung injury and ARDS. So that is why inhalational burns have a particularly bad impact on survival, because if you have an inhalational burn, it adds 17 points to the advanced bowel score, which predicts mortality. So yes, inhalational burns, anything within a confined space, must be taken very seriously. The good news is that the airway swelling and the edema of the tracheal mucosa doesn't occur instantly. So setting them up in a head-up position is important. Getting them to cough is important. And as you remember, the Bali bombings, when the Australian team led by Professor Wood, she sat all the patients who could sat them up, and that reduced the number of surgical airways or intubations that needed to be done. So that's a very simple thing to do. And if you think about it, if you've got an inhalational burn, you're going to have a chest problem because you'll be coughing, and it's better coughing when you're sat up rather than lying on your back.
Indeed. And everyone loves talking about surgical airways when it comes to burns, Winston. What would your indication of using a front of neck access airway?
Two things. The first is you've got to make a judgment as to whether there is imminent danger of complete upper way obstruction. So that's the first. The second is, where are you going to? In other words, how far are you away from a local district general hospital or a big teaching hospital or even a burn center? So that will dictate whether it's a scoop and run or stay and play. And front of neck access is probably an easier thing for the paramedic to do than intubation using RSI, because as you know, in battles about 15 years ago, we changed the ladder from RSI to surgical airway access front of neck, as you mentioned. And that's because it is easier a task to do than trying to maintain the practical skills of intubating somebody on a regular basis. So that's my view. If you're going to transfer the patient and the transfer is going to be difficult, then you might have to think of a prophylactic surgical airway.
Certainly in austere environments and resource-limited environments, the intubation is just not an option. We don't have that much RSI drugs to keep people sedated. So the FONA is going to be a better option.
Yeah. Definitely.
All right. So airway, we've talked about that. Winston, let's talk about respiration. What do we need to worry about with burns?
There are two things. One is the importance of chest physiotherapy. Do you remember when you talk about inhalational burns, there's always the chance that there will be inhaled particles that will start a pneumonitis process within the lungs. So that's the first. The second is not immediately, but 4 or 5 days down the line, if there is a front of chest or a circumferential chest burn, the respiratory excursion that is required for ventilating may be embarrassed. So it's actually like the patient being put into a tight body armor or tight bodice, and they're not going to be able to ventilate properly. So an eschorotomy, which is a way of relieving it, is critical. And this is also a process that can cause quite severe blood loss and is very painful. So you need good procedural sedation for it to be done appropriately, because you need to cut the eschar, which is the burnt wound, but you also need to extend the incisions into normal surrounding tissue. And as you know, the surrounding tissue is very hyperalgesic, so it can be very painful. And that is one of the reasons why my choice for analgesia for procedural sedation in burns is ketamine, because burn is not just a nociceptive process, it's also a neuropathic pain process. And ketamine is the only routine clinical drug that we have that works both for nociceptive and neuropathic pain. So those are the main aspects of worry in respiration. Making sure you've got good chest physiotherapy, and 2, making sure that there is no embarrassment to ventilation.
So, Winston, you mentioned pneumonitis. How would you treat that in an austere environment?
Very difficult. You might have to start using nebulizers. One of the things that we do in intensive care is to bronchoscope somebody and literally try and remove as much as of the debris that you can see. We tend to alkalize the bronchus to try and neutralize the pH. But I guess in an austere environment, just to nebulize some saline and encouraging coughing and percussion of the chest is probably all you can do, and can be very effective, especially if they started off as an ASA1 status.
That is a good overview of the respiration. So let's talk about circulation, Winston. What do we need to think about with burns during circulation?
Probably the most important thing is making sure that the patient has a radial pulse. And I always say to people, check both radial pulses, left and right. Just get in the habit of doing it on both sides. Because if you lose a radial pulse on one limb, then that might suggest that there is another reason why, like a loss of vascular supply to the upper limb. The big take-home message is that a patient is unlikely to become hypotensive within the first 6 to 12 hours after a burn. So if somebody's hypotensive, i.e. not got a radial pulse, there must be another source of blood loss. And as we used to say, blood on the floor and 4 more: chest, abdomen, pelvis, and long bones. And with the availability of ultrasound, you can exclude most of these possibilities very quickly and not be anxious about a theoretical problem. You can actually exclude it by good ultrasound scanning.
So in circulation, we've been taught the various rehydration formulas. Which one is your favorite?
For pre-hospital care, I don't have a favorite because, as you know, the various formula, Parkland, Brooks, the consensus formula is quite a wide range. 2 to 4 mils per kilogram per percentage burnt in the first 24 hours. In an austere environment, you may not have these fluids. So I think if a patient's able to drink, I think one should allow it. A, for access to fluids, but B, it's also very kind. But you've got to be careful with the patient with the upper burn airway, because they may cough and splutter and change a bad situation into a worse one and have upper way obstruction. But generally speaking, as you know, most people find it very difficult doing the calculations on burn fluid formula. And we have a further added problem that we don't have much fluids in austere environments. So the one that we published was basically a very simple mantra: small man, small burn, small bag; big man, big burn, big bag. So it's either put a 500 ml Hartmann's or a liter of Hartmann's over 1 hour, and that is your fluid balance. It's a way of avoiding overloading the patient with fluid, in which case it will have problems on the alveolar capillary interface and lead to a longer time in the intensive care on the ventilator, or be under fluid resuscitation, in which case you'll have an acute kidney injury and then you have the dialysis. So I think you've got to be pragmatic. I would just go for 500 or a liter per hour until you get into an area where the resources are better, and then you can do a back calculation of the fluids required, or you can use urine output as your indicator.
What urine output are you looking for in a burns casualty?
The tradition says 0.5 mils per kilogram per hour. I think one is probably the safer one to go for. And if you've got hemochromogens, that is, in other words, there's suspicion of rhabdomyoglobinuria, then you require at least 2 mils per kilogram per hour. So 1 mil per kilogram per hour would be my cutoff point.
You mentioned ultrasound earlier. How valuable would the IVC measurement be with hydration status in a burns casualty?
Oh, tremendous. I mean, it just gives you a completely novel way of being suspicious as to what is going on. No, I think IVC measurements in these cases, especially if it's done serially by the same operator in austere conditions, that will be the case. Gives you a sense of security if you can confirm it. No, I fully agree that ultrasound in the austere environment can take away a lot of the anxiety about the diagnostic and the trend analysis that goes on in these complex patients.
What are the obvious causes of oliguria despite the adequate fluid resus?
Well, there is something called the secondary abdominal compartment syndrome. I think most of our listeners will be familiar with the compartment syndrome involving the upper limb or the lower limb, either from crush or from electrical injury or accidental IV tissuing. The similar thing can happen if the patient has got a major burn across the anterior abdominal wall. The eschar that forms prevents the excursion of the abdominal wall during respiration, and therefore the pressure within the abdominal cavity increases. And once it gets to the critical point, it will press the ureter against the pelvic brim, and you'll get no urine output. So basically, if you have a suspicion of a secondary compartment syndrome, you can transduce the pressures within the bladder. That will give you some indication. And the second is just perform an escharotomy, and you'll be surprised at how much urine can be produced as a result of pressure.
So in C circulation, we worry about hypotension, and with burns, there is such a struggle with hypotension. Why is hypotension in the first 6 hours so significant in burns?
Very few patients are burnt and have a major source of bleed. So anyone who is hypotensive within the first 6 to 12 hours of a major burn, you need to look for another source of fluid loss. It doesn't always have to be blood loss; it can be fluid loss from other causes. For example, severe diarrhea. So just being able to look for another explanation for the fluid loss is critical.
Yeah, polytrauma, isn't it? They're burned. They could also have burned and a pelvic fracture. They could burn. Yeah. We can be blinkered as responders.
Correct.
So during C circulation, we would want to calculate the TBSA. So and there's a lot of contentions with fingers, without fingers. What are the challenges of calculating the total body surface area?
The good news is that we tend to over-calculate the area burnt in the pre-hospital environment. In the pre-hospital environment, immediately after a burn, it is very difficult to work out what is erythema and what is a superficial burn. It's only several hours, days, maybe a day later, that you start seeing the demarcation. So that's the first issue. The second issue is that you over calculate the TBSA. So, for example, it is not uncommon for us to get a message at the burn center. There's a patient with a 20% burn. The patient's taken to a local district general hospital for airway control, and it's dropped to 10%. By the time it comes to us at the burn center, it's down to 5% because the demarcation is easier. So bearing that in mind, that we overcalculate the TBSAB, this is why the various fluid formulas tend to be rather difficult to use in that situation, which is why I go for the small man, small burn, small bag, rather than relying on fluid resuscitation based on formula when the demarcation between erythema and a superficial burn is not yet being defined.
So I guess going back to urine output, if we have 1 mil per kilo urine output, do we really mind how much of the total body surface area is burned?
Yes, because it varies from paper to paper. But once you get to 20% burn, you've got a massive systemic inflammatory response, massive. And that's one of the reasons why a burn involves usually the skin, which is one of the major organs in the body. But the ramifications of the inflammatory response, it affects every organ. And so unless you spending much detail on the specifics of resuscitation, you're likely to develop multi-organ dysfunction. And then once you start getting to the realms of multi-organ failures of 4 to 5, the chance of survival becomes very slim. So this is why the size of the burn does dictate the severity of the injury. And also the age extremes. They're very young, they're very old. They'll have their own peculiar needs. For example, children, their body surface area is larger when you look at the head and neck. They lose heat very quickly. The old cannot maintain their heat. They have severe comorbidity. They may be on medications that will interfere and have disease states like diabetes and other chronic diseases that will influence the outcome. So that is why we have to be careful with the age extremes, those who are pregnant, and those who have got considerable comorbidity and concomitant medication.
Going into more depth with your systemic inflammatory response, as a austere or remote medic, what is that going to look like, and what can we do?
The main thing is to maintain the CABC approach. It is likely that the single provider is going to have to do all the duties of a multidisciplinary team in a burn center. So, like I said, have a suspicion, look at your trends on your charts, look at changes in vital signs, try and figure out what you think is going on. And the most important things, the common things occur more commonly. So just attention to detail and make sure that your nursing care, and I will allow you to explain, and it's a favorite subject of yours, what your mnemonic is.
The sheep vomit for nursing care.
That's right. Perhaps just for the sake of the audience, explain what sheep vomit entails.
So we'll cover that a bit more in our prolonged field care of burns, which is another one. But sheep vomit is something that Jason Jarvis and I came up with. He's another 18 Delta that would cover all of the nursing requirements of prolonged field care. And so basically keeping the patient warm and dry and keeping them from getting ulcers and making sure that they turn and cough and they move, and keeping them fed nutrition. So we'll cover that more. But sheep vomit is not the most nice way of remembering this, but we haven't found any other way to have people keep remembering what sheep vomit means.
I think that's a good point. I think it just depends on your way of remembering it. The other way in which the osteo provider can look into it is just going through the various organs in the body, starting with the airway and chest, and then working down. But don't forget the skin. as part of that nursing care.
Specifically in burns. You're
Yeah.
right. So moving on to disability, Winston. Often there's a low level of consciousness or an AVPU of below alert. What is your concerns with mental capacity of your burn patient?
Well, assuming there is no head injury, because you can imagine a level of consciousness will depend on your brain function. But certainly in burns that occur in a confined space, you're more worried about systemic intoxication. And that is because in such burns, carbon monoxide, hydrogen cyanide, ammonia, hydrofluoric acid, and phosphine are all possibilities that will suppress the level of consciousness. And carbon monoxide is particularly bad because it's produced in incomplete combustion of cellulose products like wood, paper, and cotton. It's colorless, it's odorless, it is not picked up by the normal pulse oximeter. You need a core oximeter to pick up these hemoglobins. And the most important thing, if you suspect somebody with carbon monoxide poisoning, is give them 100% oxygen. And that will dissociate much rapidly down to 80 minutes as opposed to 320 minutes if they want room air. And the quicker it's done, the better.
In D disability, we also talk about D drugs. What are your drugs of choice for this burn casualty?
So let's assume that we've got CABC stability. My first choice would be ketamine, because ketamine can be used in different levels to get different effects, lower levels analgesia and higher levels anesthesia. But the drug that has become more popular in Europe, certainly in Britain, is methoxyflurane. There is extensive experience in methoxyflurane from New Zealand and Australia, where they've been used in burn units and they've been used in the pre-hospital environment. It's a PCA, patient-controlled analgesia. It can last up to 30 minutes on the higher concentration, where there's no air entrainment, or can last up to an hour. So it is possible, just on one 3 ml bottle, to get good analgesia whilst you need to do painful procedures, whatever that might be. So those would be my two drugs to go to. Of the opioids, my favorite is fentanyl, because again, it's a quicker onset, it's cardiostable, and my drug that I would very reluctantly have to use in an osteo environment is morphine. And we know that morphine in major trauma, morphine in severe burns is just asking for problems, because you tend to get a cardiovascular collapse.
Speaking of morphine, you've done some research on topical morphine. Can you explain that, please?
Yes, morphine receptors are widely located within the body. And we have opioid receptors in the skin. Now, you have opioid receptors within joints. So in osteoarthritis of a major joint, if you wash the joint out and put some morphine in, you get pain relief. And a few years ago, we started putting morphine topically by taking 10 milligrams of morphine, dissolving it in sterile water, not saline because saline stings, and then spraying it on the clean burnt wound, and then covering it with cling film. And it is so safe, and it's become so popular in our burn center, that we now routinely use it in following a burn clean and before the change of dressings.
Is there any contraindications for doing that pre-hospital?
I would say the only relative contraindication would be making sure that the responder has got the competencies and the top cover to do so. So it is not something that you would do for the first time in the middle of nowhere. My suggestion is that you get these clarified before you go out on your mission, or go and spend some time attached to a burn center where this is done. I think when you see it and you see how useful it can be, that would be my only worry.
So the first 20 minutes is cooling the burn anyway, so we're not talking about the first bit of morphine straight away. So for cooling the burn, what is your number one option for cooling the burn and warming the patient?
The important things about cooling the burn is to use running water flowing over the burn wound. And it should really be at room temperature, anything between 8 to 25 degrees centigrade, for a minimum of 20 minutes. Now, it can either be done by running water flowing over the burn, or spraying the area, or sponging. Wet towels are not as effective, and they really need to be changed frequently for it to be effective. And the other bit is to remember that cooling a burn can be helpful for up to 3 hours from the time of the burn. And definitely do not use ice or cold water because that may aggravate the burn, because it's a source of another source of burn. And you've got to be really careful avoiding hypothermia, especially in children. And the other thing is just common sense, really. If you've got cooling the burn, it will also provide pain relief. So there are good reasons for that.
It does bug me when I keep reading putting ice on a burn, which just constricts the tissues and traps the heat in. And my eye twitches a bit when I keep hearing that. And yeah, the Australians are still saying putting fabric on the burn, which then I'm sure is going to stick to the burn, and then putting water on it. I just can't understand that. Or in the 80s, when I first started, you just put gauze on the wound.
Yeah, and the problem with all that is that when it gets stuck to the burn, it's very painful when you're getting it removed. So this is why I'm a big fan of cling film. Cling film, just the ordinary one that's available for wrapping up sandwiches. It doesn't have to be of a medical grade. When loosely applied, it also provides analgesia. It keeps the wound moist. It allows inspection to be done. And to me, that is probably the best emergency wound dressing, because immediately after a burn, the wound is sterile. So if you can cover it up as quickly as possible with longitudinal strips, say for the limbs, because you mustn't make it circumferential, because that burn wound is going to expand over the next few hours and therefore will constrict. So I'm a big fan of cling film.
It is sterile as you pull it off the roll.
Correct.
And can you explain how cling film will reduce pain?
Yeah, I remember when we talked about pain, the classification of pain is basically nociceptive, neuropathic, or nociplastic. Nociplastic covers things like IBS, TMJ dysfunction, bladder pain, etc., etc. Nociceptive pain is good pain. Everybody understands nociception. You break a leg, it heals, the pain goes away. Neuropathic is when there is damage to the nervous system, either peripherally or centrally. So in a burn, you've got a peripheral neuropathic problem. Now, one of the features of neuropathic pain is allodynia, and that is where a pleasant stimulus, like stroking the skin, becomes exquisitely painful. For example, if you've got a major burn that is exposed and you open the door to the room, and if air wafts over the patient, they get extreme increase in pain. By covering the burn with cling film, it acts as a second skin. So the peripheral receptors are not stimulated, therefore you get pain relief.
And how long should the cling film stay on before you transition into a gauze dressing?
Depend. This is more likely to be an issue in prolonged field care. I guess if it's several days down the line, say 2 or 3 days down the line, the wound will change and become complex, and I think then another intervention is required, and that we can discuss in detail when we talk about prolonged field care.
Fair enough. So moving on to environment. So burns are poikilothermic. Can you tell me what that means?
Poikilothermic means fish-like. There are two areas in medicine where patients become poikilothermic: the premature newborn and the burn patient. And that is why both in neonatal units and in the burn center, the temperature of the rooms are kept at a high level, because the poikilothermic, i.e. fish-like, you take the temperature of the surrounding, and therefore to minimize heat loss, you have to keep the ambient temperature at a higher level. That's really critical. And as you know, Hypothermia in burn patients is independently associated with mortality. Therefore, any mitigation is important. So trying to keep the wound covered and exposing only the area that's being assessed is important. Temperature measurement is critical. And when we talk about exposing the patient under E, remove all clothing and jewelry. If the clothing is stuck to the burn, just cut around it and then cover it up with cling film or a clean sheet. And most important is keeping the patient warm. It's not simple. It's not easy thing to do, but it's something you need to think about how you would manage this in a austere environment. But as you know, temperature control or hypothermia, is a part of the triad for trauma death. So if you become cold, you don't clot, and if you don't clot, you can bleed out. So it's a vicious circle. And this is the point we made earlier on. A good medic is one who pays a great attention to detail, because everything sort of contributes to the final outcome of the patient under your care.
Okay, Winston, we've talked about the initial assessment and management, the CABCs, and this is when we generally would move into prolonged field care, which will be another podcast episode. The last thing to think about is when to transport, when to refer a burn patient. So if you're in an austere environment, what are the indications for the austere medic to know that they need to evac this burn casualty?
I think in an austere environment, you have to know where your next level, higher level of medical resources are going to be. It may not be very obvious. It may not be the closest place. It may be something further on, and there may be logistic problems why you can't do so. As a general rule, any burn beyond 10%, any burn involving the head and neck, any inhalational burn, any electrical burn, any burn across a major joint, any burn that involves chemical contamination or poisoning, any lightning strikes, these really need to go to the best possible center. We're lucky in the West that we have a graded approach to hospital care. We can go into a local district general hospital, we can go to a teaching hospital, and then we can go into a burn center. So I can't really give you an answer on that, but do not sit on these patients, because the problems of multi-organ dysfunction, multi-organ failure is going to happen, and the quicker we get them out of there, the better.
A valid point. And as a paramedic, I'm always grateful to have telemedicine available for consult on a burn specialist or a top cover doc to help discuss on the medical evacuation discussions.
Yeah, I think you're so right. Burn injury, just like dermatological illnesses, are best done by telemedicine because they can see it. And that's another reason why I like cling film. You don't have to undo it to show the person on the other side of the video the situation. And that's another reason why I like vital signs displayed on a chart, because it's easy to photograph it or show it on the video for people to see the trend analysis. I would say top cover by telemedicine is really the golden standard.
Definitely. And I'm glad that you've mentioned trending throughout the entire discussion. People ask me, what is austere critical care? And that's the first thing I mention is you want to be a good medic, you need a trend and trend over time.
Yeah.
Do you have any other last thoughts on burns before we end this podcast?
I think the main thing is to remind the paramedic that your involvement with the patient is just the first step in this long journey that they're going to go through. And I think if you manage these patients well, if they are conscious and you treat them well, explain things to them, explain what you're doing, explain the importance of chest physio or whatever, and provided you provide a good humanitarian approach to these patients, that will shorten the time in hospital, that will shorten the incidence of PTSD, and hopefully help them to make that long journey to recovery and return to society.
Thank you, Winston. It's always a pleasure to talk to you about these topics that you're so passionate about. And I look forward to hearing the second part of this, which is the prolonged field care of burns.
Thank you very much.
This has been a presentation from the College of Remote and Offshore Medicine Foundation. If you would like to earn CPD credit for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credits, free access to the virtual field guide, and discounts on our e-learning courses. You can join the team on the college website, which is Corum, C-O-R-O-M, corum.org.